Okay, so if ours was a mature paper, mine is an immature paper, because I won't be sharing results that are just coming out. What my co-author Allison Hoffman and I were doing was looking at retiree healthcare costs, and this is what I characterize as a complicated problem of financial literacy, because it's actually difficult to figure out. You want to know who? I'm that one. Um, it's a complicated problem because it's actually genuinely complicated to figure out what your out-of-pocket costs are going to be in retirement for retiree health care. And just to give you an idea how complicated it is, this is the definition we use for our survey. It's expenses that you pay, including insurance premiums, not including payments made on your behalf, so not money that Medicare paid to the hospital directly, but just what you pay for your personal expenses as opposed to family expenses, not long-term health care costs, because that's generally considered to be different, and we want you to think in terms of current dollars. We don't want you to inflate into the future. So these are actually all key assumptions that you've got to kind of specify if you want to get these estimates made. So this is a lot different than a bond question or some of the financial literacy questions we've done before. The way that I kind of think about it is if you want to know the answer to this question, all you need to know is your life expectancy and your monthly expenses. You need to make an adjustment for the final years of your life. And then there's some other uncertainties about your personal health, medical inflation, and government policy. But if you think about all of that, you can just figure it out. So that's what we're interested in looking at. Now, the paper has two basic parts. There's a literature review about what the experts say. And actually, Matthew is one of the experts that cite it. There are a number of them. There's a whole literature about retiree health care costs that's interesting and complicated. And it measures things in a lot of different ways: monthly cost, lump sum cost. Do you include dental? Do you include premiums? It's actually a hard work to figure this out. But we did our best to kind of distill expert views, and I just tell you to look at Allison's section of the paper to read that if you're interested. Then we used Ari's wonderful American Life panel to do a survey of roughly 1,700 respondents between 40 and 80, divided into 5-year age cohorts. We had a couple of questions of background about health, financial sophistication, and expectations about life expectancy, and then 3 treatments that we basically did. One was a down and dirty, just how much are you going to spend on retirement healthcare costs and final year of life, and what's a lump sum estimate. So just 3 quick questions with no context. Then we had 2 treatments that gave more context, asked people about what insurance policies they expected to have, how much they thought they'd pay for premiums to get them thinking about there'd be premium costs, asked them what other costs might they have, and then costs at different ages in retirement, 65, 75, 85. So we were trying to help them break down the costs. And then treatment C, we did the same kind of framing as B, but we actually added in information saying the typical Medicare premium is X, the typical Medigap premium is Y. Usually your out-of-pocket expenses are this ratio to premiums. Life expectancy is this. So we did a lot of anchoring to help people along to make the estimates better. And then we did some follow-up questions about risk that I'll talk about. We also did long-term care stuff, which I won't talk about today because we're still analyzing. Okay, summary of findings. Expectations about insurance coverage vary. So the question, the basic question about do people know what their coverage is going to be in terms of having insurance of some sort in retirement. Well, here's an interesting example. People's expectations about Medicare. So we asked them the likelihood that you would have Medicare treatment, Medicare coverage in retirement. The actual answer is currently 95% of the people have that coverage today. The average response was 72%. This is something that people learned better as they got older. So the youngest cohorts, 55% likelihood. Older cohorts, 91%, 92%, pretty close to the actual number. So in contrast to David's work about the addledness of the elderly, actually they were better on this. Of course, they were under Medicare, so that you might expect them to be better. The younger people also overestimated their Medicaid coverage, which they kind of learn more about over time. So it could be that the young people were just confused about Medicaid, Medicare, which is it? I know it's one. And as they get older, they kind of figure it out. They still radically overestimate Medicaid. Only 15% of the population have it. The average of 40% thought they'd have it. So that's kind of an interesting result. It's sort of interesting whether the younger people on Medicare were also kind of thinking, I'm not sure Medicare is going to be around. And what I'm estimating is that. Are they kind of making the sophisticated prediction about Paul Ryan's plan or not? That's something we were interested in. And I can say more about that in a second. But interesting figures, and I talked about Medicaid, but there's a variation. Expectations on premiums affected by treatments and narrows with age. So we asked people what they thought they'd pay for their insurance in retirement. And let's just focus on here. In these estimates, it's sort of interesting, and we tend to report medians as opposed to means because there's some outliers on the high end that messed up the means. But the treatment B folks kind of thought typically that they'd pay $120 for Medicare, all Medicare, that's Part D and regular. Treatment C, when we gave them more information, actually upped that to $135, which is actually pretty close to the right number. If you take Part D premiums, which are about $40, and the typical traditional, which is about $100, that's a pretty good estimate. Of course, we told them the answer, so they got it kind of right with a Q. And they also kind of narrowed in the distribution. So the treatments really helped in narrowing the distributions. So the errors were less pronounced, and you see that kind of throughout. So treatments affect estimates about premiums and narrow the range of distributions. This is another presentation that's kind of an interesting one. It also speaks to the wisdom of the elderly. These are the cohorts divided by how they estimate it, with the dots in the middle being the median, and the bands, or those sticks, being the 25th to 75th percentile. So what you're seeing is Medicare estimates of premiums through our cohorts. We see a downward glide a little bit. This could be the younger people expecting higher premiums, but what you really see is the elderly making better, narrower estimates. Of course, they're in the Medicare gap, but there is sort of some learning over time, which is a kind of interesting. The dots on the top are the 90th percentile estimates. So a lot of people are way overestimating, which is kind of an interesting fact that I'll talk about in a second. But on premium, that's what you see. The larger question of total cost. What do people expect about total cost? So that's premiums plus other out-of-pocket expenses, all the variability that you have in your actual cost from deductibles, copays, things that aren't covered. They are less affected by treatment. So when we gave people information about premiums, it affected their premium thinking. It had a less pronounced effect about their total cost. So they didn't really incorporate the training. There was still some narrowing with age. So monthly average premiums, $200, $200, $220 for treatment C. So that's what people kind of were estimating by the treatment group. So not much of a treatment effect here. A little bit of one. The variation narrows a bit, but not as much with the premium. So they kind of were losing that anchoring a little as we ask broader questions. Here is the treatment. Here is a presentation of data by age cohorts. So this is what you see with the age cohorts. More variation still with the younger. A modest rise going backwards, but not as pronounced as on the premiums. So this does not seem to be reflecting the younger people are expecting Medicare to go away kind of effect. It seems like they're making expectations about monthly costs that are consistent. Now, the question of how well are they doing against the experts? Well, it's sort of an interesting question. What do we expect them to be doing against the experts? Our expectations going in was that they would underestimate the cost of their medical expenses. Then we had a question of, well, what do we mean by, what would the right answer be? This yellow band reflects the 50th to 75th percentile of what the experts say the costs are going to be. So you might think that's the right answer. And you know, kind of a little bit of wisdom in crowds here, that the medians are pretty close, at least to the median in some places. Where I think we're a little bit less comfortable is with the younger folks. So if you ask people what are healthcare costs going to be in 2020 or 2030, they're clearly going to rise. And it doesn't seem that the younger folks are generally picking up that rise in their expectations. Maybe they're overreacting for us to saying you should use current dollars, but there doesn't seem to be the kind of upward drift for the medians that you would expect. Lump sum estimates. So the other way of thinking about this, and actually in some sense for financial literacy, the more relevant way of thinking about it, I think, is how much money would you need at retirement in order to have enough money for your retiree health care expenses. So you need to incorporate in life expectancy to do that and rising over time. I should, by the way, say I'm not going to give the data on this, but we do have a lot of information about how much people think costs are going to increase while they're in retirement, and generally the answers were pretty reassuring, and that most people recognize that they would go up over time and also be higher in the final year of life. But let me just give you a little bit of summary about the lump sum estimates. In general, it's similar to the monthly estimates. So here's treatment A, B, and C. We're not getting a whole lot of variation in the median estimate. Most people, the median estimate is $50,000 pretty consistently with all treatments. There's a little narrowing with treatments B and C, so giving some more information helps narrow, but it doesn't change things. Here is the cohorts, and again you're seeing a similar effect of 50,000 pretty consistently, and if you put in the expert estimates, again you're seeing they're modestly beneath the range for the elderly, more beneath the range for the younger cohorts. There's some educational work, I think, to be done back here to get those numbers up because they do seem to be lower than they should be. Now, one of the other questions, going in, we thought people might be hyperbolically discounting. That we thought one of the things that might be going on is that they might have the monthly cost right, but they would underestimate the lump sum cost by over-discounting in some sense. And you can sort of, in some sense, tell that that hasn't happened in a big way because the bands are in roughly the same relationship. Actually, one of our interesting findings is they were clearly not hyperbolically discounting. I don't know if this is a term in the literature, but if it's not, I want to copyright it. They were hypobolically discounting. And let me explain how we come up with that. We asked people what their life expectancies were. We asked them what they thought their expenses were going to do during retirement. We could therefore derive an implied lump sum. So based on how long they thought they were going to live and what they thought their expenses were, we could derive an implied lump sum evaluation, which is what I've done here. And if you look, one of the things that's interesting is these numbers are like 45,000, 30,000, 35,000. They're beneath 50,000. So the actual implied lump sums were lower than their actual ones. So when they did the lump sum, they actually interestingly pushed things up rather than pushing them down. The other thing that's interesting, and to give the scale effects correctly, this is $100,000. The 90th percentiles on the implied lump sums were only rarely over $100,000. If you go to the real results, that's the $100,000 line. So one of the interesting things that's going on is people are pumping things up, and they're way overestimating. A lot of people are just coming up with crazy numbers based on what they've said before. And this actually might be discouraging their savings a fair amount going forward if the numbers are just ridiculously high. But I think this is kind of an interesting effect, and we're going to explore it more. I'm not going to be able to get through all my slides given the pace that my cards are going at, but let me just say a couple of things that are interesting for purposes of this group. One of the questions we were interested in is were people off of the medians in the correct ways according to the expert literature? So were the people that were below the median likely to be folks that would have below median expenses? and above median likely to have above median expenses. So there were a couple of things in the literature that it's clear are correlated with higher or lower healthcare expenses. The one that's kind of best known is gender. Women live longer, as we've heard a couple of times. They have higher healthcare expenses than men do by about 40% on a lump sum basis because of life expectancies. Amongst our surveys, women's estimates of their lump sum needs were 50% of the median of men. So men, maybe men are wimps, they all said they needed $60,000 a median. Women said 30. That's clearly incorrect. It should be in the other direction. So that's kind of an interesting result. That's a point for interesting education to be done. The wealthy actually spend more on out-of-pocket expenses. Much Medicare medical expenses is discretionary. They don't get Medicaid. That's in the right direction. Health is an interesting direction. The people who are healthier say they need more money than the people who are sick. That may be correlated with income, and we need to look at that a little bit more, but there's a difference. Financial sophistication actually doesn't seem to have much of an effect at all here. So this self-assessed financial sophistication doesn't seem to have much work. I won't have time to talk about this, but we did a lot of risk assessments about whether people understood what risks were likely to affect things. The results were ambiguous there. One thing that does seem to be clear is respondents don't quite understand how susceptible they are to higher costs because of their health outcomes. If you were sickly, your expenses can be 50 or 100% higher than the median. People underestimated that. They also seem to be insensitive to the significance of policy changes in the Medicare program in particular, underestimated how much that could increase their costs. So that's another area of further work that could be done. There's a lot of additional work that could be done in this. Okay. In sum, it's an important project with more work that could be done. The one thing I would just say is the coordination with medical cost researchers. There are a lot of people, and there's a lot of papers, and they're cited in our article, about what research, about what costs are going to be. They're largely focused on cost containment and the medical side of things. They're not designed to educate folks. So this is an area that's, this is a huge negative annuity that we're all facing. And we have a system where we're expected to be covering this. But it's really hard to get information. So it took us a year to do the literature review. Most people, as I'm talking about what you can do over lunch, you can't figure this out over lunch. You can't even figure out at Harvard over lunch what your premiums would be for their employer-sponsored health care coverage that you may get. This is a really hard problem that more work needs to be done. There's lots more to do with our data set, and there are plenty of policy implications, but this is an undermined area of research, I would say. Sorry for going over.